Hello. Good afternoon, I suppose. My name is Ginger, Ginger Flynn, and I am an EMS liaison at UC Health Memorial EMS in Colorado Springs. And today I'm going to talk to you, with you, about EKG Basics for the EMT. This is for the Plains to Peaks Virtual Conference in 2021. So here we go. We do have some objectives. We're going to review the appropriate times to use a cardiac monitor as an EMT or as an EMS provider in general. We're going to discuss the steps to consistently read an EKG strip. We're going to review the causes and the complications of different heart rhythms. So if you recognize them, what kind of questions you should ask about possible causes and some different treatment options. Discuss how to put on a 12 lead on a patient, review coronary blood flow, and then at the end practice identifying some different rhythms. I have no financial disclosures for you, so we will go ahead and start. I'm going to turn off the webcam so you don't have to look at my face. And here we go. So you are an EMS provider and you have a cardiac monitor available to you. There are certain times when it's appropriate to attach the EKG monitor. Now certainly if you have enough people and you have enough time, you can attach a cardiac monitor to anyone that you want to. But there are some certain instances where it is kind of the standard of care and really important to think about using the monitor. If your patient has chest pain, shortness of breath, if they're unconscious and you don't know why, if they have upper abdominal pain or sometimes called upper epigastric pain, or if you think the patient may be having some cardiac issue, but they're not necessarily complaining of the standard signs and symptoms. So if they have extreme fatigue, some backache, some fluttering in their chest, they just don't feel well, they have a cardiac history, or they have a significant family history, those are all reasons that you would want to attach a cardiac monitor to your patient. This is assuming if you're an EMT that you've done your BLS skills, you've done a good assessment, you've taken vitals, you've started an IV if that's appropriate, and you've done any appropriate BLS interventions. Then if all of those things are done, things that you can do, then it would be good to put the monitor on them and see if you can facilitate them getting care sooner. So if you're able to print out a strip and either hand it to an ALS provider or hand it to the hospital or give it to, obviously flight crew is an ALS provider, or even if you scan it or transmit it to the hospital, they may be able to get that patient into the appropriate care faster because you thought to put the monitor on them. Now, you've all probably seen really good monitor tracings that look like a rhythm generator or they look pretty textbook. You've also probably seen rhythm strips that look like they're bouncing down the road in the back of a pickup truck down an old country road. It's really hard to read those that have so much artifact and movement in them. So there are some tips that I can give you, or you have maybe heard, about how to get the best possible tracings. So first, the patient needs to be clean and dry. If they were really sweaty, if they were out in the rain, the electrodes aren't going to stick to them, so you have to dry them off. This is really challenging if your patient is having an MI and they have all of the diaphoretic sweat that comes with having an MI in some patients. You can dry them off and dry them off, but they continue to sweat and the electrodes just fall off all over the place. There is one little trick you might try if you were to get just a plain stick of deodorant. Sorry, not deodorant, but antiperspirant, like unscented, just the basic antiperspirant, and you roll a strip on where you would put the electrodes and then just lightly wipe it off with a towel. Sometimes that helps to make the electrodes stick a little bit better. If they have excess chest hair, you want to get rid of that so the electrodes will stick better. Now, the first thing that you're going to put on the patient are the 4 limb leads. They're called limb leads for a reason. They're meant to be on your limbs, your arms and your legs, but some people do put them on the chest if you can't get to their legs or you can't get to their arms. And typically it's shoulders and like ankle area. They are marked upper right, lower right, upper left, lower left, or ULLL, and so on. There's also a little saying, because they're color-coded, if the letters have rubbed off from use, white on right, so the white cable goes to the upper right shoulder. Smoke over fire, so smoke is black, so smoke or the black electrode would go to the left shoulder, the red one would go to the left leg, and then grass under clouds or grass would be the lower right. You want your patient to sit still and try to relax while you are taking this tracing, which means they shouldn't be talking and you shouldn't be talking to them. They should uncross their arms and their legs, lean back, and just relax. If they're shivering, if they have tremors, all of those things can cause extra artifact. And also if they are near a microwave or a TV or a computer, that can sometimes cause some artifact. And that kind of artifact is usually a heavier black line. All right, so now that we know how to get a good tracing, what can we do with this information? So this is a class on basic interpretation, primarily of just a regular 4 lead, a little bit on 12 leads at the end. Technically, EMTs are not allowed to interpret the information, but knowing how to put on the cardiac monitor and knowing when to use it are really beneficial. If you have an ALS provider en route, you can give them that strip, and that will help them assess the patient a little faster. You can transmit the strip or a 12 lead to a hospital to facilitate the appropriate care. Different agencies have different ways of transmitting those 12 leads or the cardiac strip. In either of those situations, the EMT can use the monitor's interpretation. So if you're doing a 12 lead at some point on the printout, it will say what it thinks is wrong with the patient. And you can use that to help give the appropriate care to your patient. And that's also something that you can send to the hospital to give them a heads up for appropriate patient care. All right. So when you're looking at a cardiac strip, the lead 2 is the one that's most commonly used because it follows the current of the heart. People usually have a preference for what they like to look at, but in general, lead 2 is the most common preference. And an EKG strip can show you a lot about your patient. It will tell you the heart rate, and we'll talk about how to measure the heart rate from the strip. It will tell you if their rate is regular or irregular, if you might suspect AFib or some drop beats or things like that. And then it also will tell you about the time it takes to conduct an impulse through the various parts of the heart. It can't show you about the heart's ability to pump. So a cardiac monitor can really just tell you about the electrical part of the heart, not about the actual muscular part, which is the part that pumps. So you might ask yourself, well, how am I supposed to find out about the heart's ability to pump? Well, that all comes from you. That comes from feeling their pulse when you first get there, right? You introduce yourself, you shake their hand, you just gently find their radial pulse, and that tells you a lot about how strong it is, and if it's regular or fast or slow also, very fast, long before you can get the monitor attached to them. You can also look for swelling in their feet or their dependent areas if they're bedbound to see how well the heart is pumping, and you can also listen to breath sounds. All of those things will tell you a little bit about the heart's ability to pump, along with your good assessment and questioning. So the paper is standardized, and in the machine, it moves across a stylet to create that EKG wave. If we're going across, a small box is 0.04 seconds, and we're going to count some boxes here. 5 small boxes make up a large box, and the lines are a little darker or heavier around the large boxes. If we're going up, 1 small box is about 1 millimeter. When you hear people talking about somebody having some ST elevation, they might say he's got 3 millimeters of elevation in these leads. Well, they're looking at a 12 lead, and they're looking at 3 small boxes of elevation to create that 3 millimeters of elevation. There are some markings at the top in 3-second intervals. So we count a heart rate in one way by counting how many beats are in 6 seconds. And that's why we use those 3-second markings. So here you can see a big box is 5 little boxes. 1, 2, 3, 4, 5. 5 vertically and 1, 2, 3, 4, 5 horizontally. So 1 big box is 0.2 seconds, or 5 big boxes would be 1 second. 3 seconds is 15 boxes, or if we look at the top here, this is a 3-second marker, and this is a 3-second marker, and then this one over here makes a total of 6 seconds. And 1 small box is just 0.04 seconds. Okay, so talking about the basic parts of an EKG rhythm, we're going to talk about each of these parts a little bit, and this picture will come up again. So we'll move on. So the P wave, which is right here, is the depolarization of the atria. So this is when the atrias contract, and this is the electrical representation of those atrias contracting. The PR interval, which is helpful when you're looking at heart blocks, which is going to come up in a little bit, is from the beginning of the P wave, so from here to the beginning of the QRS complex, which is right here. And if we had boxes, you would be able to count. If there were 3 to 5 small boxes in that PR interval, that would be normal. If it was longer, then that would be considered a first-degree heart block. The QRS complex is a representation of the ventricles depolarizing. So the electricity has gone through the SA node, AV node, bundle of His, bundle branches, and the Purkinje fibers are now depolarizing, causing the ventricles to contract. And that is this complex right here, the QRS. And if we had our paper in the background, it should be 1 to 3 small boxes. So it should be fairly narrow in size. The ST segment, so this right here, is the ST segment. We're not really so concerned about the time of it, although there is something called long QT syndrome that can be an issue for patients, causing them to go into VFib and things like that. What we're mostly looking at with the ST segment is it on the isoelectric line? So this here is the isoelectric line, and and that's where it should be. If this went up, if the ST segment went up to here, that would be considered ST elevation, and we would count by the boxes how far up it went to describe millimeters of elevation. If the ST segment is lower and down here, we would call that ST depression. We're not really going to measure that, but that's a sign of ischemia in the heart or lack of oxygen in the heart. The T wave represents repolarization of the ventricles. So they are getting ready to do their business again. They're getting ready to depolarize and cause those ventricles to contract again. So it happens. So the heart beats again and again and again and again. This should be like nice and rounded like it is here. If it's really pointed, like if we have a T wave like that, that's a sign of potentially some elevated levels of potassium in the blood or hyperkalemia. So if you were to see that, you might ask about dialysis and urine output and things like that. This can lead to a life-threatening rhythm and cardiac arrest. And then finally, we have the U wave over here. And this is not always present in every rhythm. It could be a sign of high potassium or other electrolyte abnormalities. If your patient takes a medication with a cardiac side effect, they might have a U wave. All right. Now that we know the different parts of the of a cardiac beat, we can talk about how to identify the rhythm that that person is having. So every time you look at a cardiac strip, you should look at the same 5 things every time. Every time. That way you are thorough and organized and you won't skip something. So the first thing we're going to look at, it's not on here, but we're just getting a kind of a general impression of what it looks like to us. Does it look, so just a general idea is the first step. And then we can kind of dig into the 5 specific things to look for. The first is the rate. So like I said before, you can look at the 6 seconds, count how many complexes are in that 6-second strip, and then multiply by 10. Or you can count either forwards or backwards when a QRS complex falls on one of the big box lines or a heavier line. And then you're going to count back big boxes, 300, 150, 100, until you get to the next QRS complex, and that would be the heart rate. Obviously, it's not 100% accurate, but it gives you a pretty good idea of the patient's heart rate. So that's the first thing we look at, besides the general impression. The second thing we're going to look at is the rhythm, to determine is it regular or irregular. So we're going from the R part of the QRS complex to the next R of the QRS complex throughout the strip that you have to determine if it is regular or not? We'll come back to these things. Third thing that you're going to look at is the P wave. Is it there? Is there a P wave for every QRS complex? Does it look the same? Is it upright? Those are all things that you want to look for on the P wave. Fourth thing is the PR interval. So we want that to be its normal length or duration. And remember that PR interval was 3 to 5 small boxes. Finally, we look at the QRS complex. Do they all look alike? Are they the right duration or time? And again, that should be 1 to 3 small boxes. Now on some of these examples I have, it is a little hard to count the boxes, but I have some at the end that are a little easier to count, and we can do some practice ones. All right, so this is normal sinus rhythm. So if we look at those 5 or 6 different steps, we're going to hopefully come up with normal sinus rhythm, because that's what this is. So my general impression here is that it looks pretty normal. I don't see anything like crazy unusual in this. So that's my general impression. So then I look at the rate. And again, in my 6-second strip, so 6 is from here to here, and this is the 3 marker. We've got 1, 2, 3, 4, 5, 6, 7 complexes. So 7 times 10 is going to be 70. So this person has a heart rate of about 70. The other way we can do it is count our big boxes. So if we look at this one is pretty much on this heavy dark line or heavier line. You can go forwards or backwards. So if we go backwards, we would be at 300, 150, 100, 72. So this next QRS complex is right about on the marker for 72. So we can pretty confidently say this person has a heart rate of about 72 beats per minute. Okay, that was number 1. Number 2 is the rhythm. Is it regular? So this is an R wave, this is an R wave, this is an R wave, this is an R wave. And if we look at the distance between each of these, they all look to be about the same distance. So we can call that regular. Next, we're going to look at each P wave. So it looks like every QRS complex, that's the big up-down, has a P wave right in front of it. And each of these P waves look to be the same, or we might say they have the same morphology. They look the same. We can also say that they're all, well, they all look the same, so they're all upright. Okay, so number 4 is the PR interval. And this is where it's a little hard to count the boxes on this, but from the beginning of this P wave to the beginning of this QRS complex, it's not quite a big box. So my guess was about 4-ish boxes, which is normal, right? We want 3 to 5. And then the last step is looking at the QRS complex. So that one, we start here and we go over to about here, and that appears to be about 2 boxes, 2 small boxes, and it's supposed to be 1 to 3. So in this strip, everything is fairly normal. If you remember from EMT class, normal heart rate, to make it the normal sinus rhythm, is 60 to 100. So 72 is right in that normal range. Okay, so that's normal. Now we're going to look at some abnormal ones. This one is a sinus bradycardia. If we look at it, general impression, nothing really crazy going on in this strip here. So now we're going to count the rhythm, or the rate, I'm sorry. So if we were using the 6-second method, we would have 1, 2, 3, 4. So it would be about 40 beats per minute. Or we can start with this one, which is more or less on the line here, and we would go 300, 150, 100, 75, 60, 50, 43, 37. So if we count that way, it's a little bit, probably about 35 or so would be the heart rate on this person. Looking at the P wave, or sorry, the rhythm, this looks to be pretty equal between each one, so we'll call it regular. So it's slow and regular. There is an upright P wave for every QRS complex. We have this amount of space, so looks to be about 3 to 4 boxes for the PR interval, and then the QRS complex is about 2 to 3 boxes also. So besides the rate, everything else is fairly normal. So this would be sinus bradycardia, less than 60. So somebody who has sinus brady, or sometimes we just say they're Brady, this can cause decreased cardiac output. The heart in some patients isn't beating fast enough for them to eject enough blood out to the rest of the body. It can also cause low blood pressure. Because the blood pressure is low, there's decreased cardiac output to the heart muscle itself. The heart may not be getting enough oxygenated blood, so there's some chest pain or angina, and the brain may not be getting what it needs, so there can be some confusion, or they can be unconscious, some CNS depression. They can also have some syncope, some dizziness, some shortness of breath, pale, cool, clammy skin. They may be intolerant to exercise or moving around the house even, like maybe they can't carry their laundry basket up and down the stairs or walk out to the front yard to get their mail just because their heart isn't beating fast enough. This can be caused by beta blockers. It can be caused by hypoglycemia, hypothermia, if they have low thyroid function, or if they're having an MI and it involves the right coronary artery. Those are all things that can cause bradycardia. Now, it is important to note that this might be completely normal for a conditioned athlete, somebody who does some long-term endurance type activities on a regular basis and they're very fit. They may have a resting heart rate in the 50s or the 40s, and we are not going to treat bradycardia unless they're symptomatic. And the treatment, besides maybe a little bit of fluid if they're hypotensive, is medications from an ALS provider or electricity from an ALS provider. So as an EMT, you recognize it, do a good history, and then pass that information on to whoever you pass your patient off to. And again, they may only get treatment if they're symptomatic. Okay, we already know that this one's sinus tachycardia, meaning it's a heart rate of greater than 100, but let's go through the steps and see, again, if everything else is normal. So the more you do this, these 5 steps, the faster you will become at it, and you can look at it. And again, EMTs can't read the strip, but for your own personal benefit, you can certainly read the strip. You just can't use that information in your care. Okay, so nothing crazy. Nothing crazy with the general look of this, right? Everything looks pretty normal. If we were to count the rate, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 10, a heart rate of about 120. And if we wanted to do it the other way, just for fun, so this one pretty much starts on a heavy line. So we go back 300, 150. This next one's 100. So we're somewhere between 100 and 150. So about 120. It's a little bit heavier to the 150. So somewhere between a heart rate of 120 and 130. It looks pretty regular from R wave to R wave, so we can call this regular. We've got an upright P wave for every one, and I really can't count these boxes, but they appear to be in the right range, 3 to 5 boxes. And then it looks pretty narrow, and it definitely is between 1 and 3 boxes. So the only thing out of the ordinary is the rate. So sinus tach. So this can cause some problems also. It can be caused by, not caused by, but it can cause decreased cardiac output because the ventricles don't have time to fill. It can be caused by hypotension. So if their blood pressure is low, the heart's going to try to compensate by beating faster. Exercise, obviously, if they have been actively exercising, their heart rate needs to be faster to keep up with the oxygen demand of the muscles. If they're anxious because they're sick or they were in an accident or they had some kind of trauma, they may have some tachycardia. If they're sick or hypoxic or their pump just isn't working, then they can be tachycardic. They may also complain of dizziness, shortness of breath, lightheaded. They might feel some palpitations, some chest pain, and they may pass out. A lot of those things were similar to the bradycardia. And again, if the heart's beating too slow or too fast, the right amount of blood isn't being ejected from the body with each contraction. Stress, pain, hyperthyroid, an electrolyte imbalance can also cause the sinus tachycardia. And generally our treatment is to treat the underlying cause. So if they've been exercising or they're anxious, we want them to calm down. If they're hypoxic, we give them some oxygen. If they're hypotensive, we give them some fluid. And all of those things should slow their heart rate down if it is indeed a sinus tachycardia issue. Sinus tach usually doesn't go past 150. If it's over 150, we're looking for some underlying cardiac cause of the problem. Unless, of course, they're exercising really heavily and they haven't had time to cool down. It may be more than 150, but not sustained and still be tachycardia, sinus tachycardia. All right, so this one has some abnormalities in it. If we look at the P waves, there's a P wave here, and a P wave here, and a P wave here, and a P wave here. These two look like they're coming a little bit earlier, and their P waves aren't there. So we're going to call this premature atrial contractions. This is another one of those where we're not going to actively try to treat it. It's usually benign. It can be caused by caffeine or nicotine stimulants, alcohol, hypoxia, or it just may happen. Stress, infectious diseases. They may feel like their heart is skipping a beat, or they may feel like they have some palpitations, but it's usually not something they're going to be treated for in the field or even in the hospital, just because it doesn't cause a considerable problem. If it does, they will, a cardiologist will treat that problem. Next, we have supraventricular tachycardia, or SVTs. And this is a scary heart rate for a patient, but it's kind of an exciting one for EMS providers. So if we wanted to count the rate on this one, we can find this one. So we're at 300 and then past 150. So this person probably has a heart rate of about 180, and they may feel not very good because their heart is beating so fast. So the problem comes from above the ventricles. That's why it's called supra, above. So it's usually above 150 in order for us to call it SVT and treat it. Sometimes the P wave is really hard to see because the heart is beating so fast. This can be caused usually by some kind of heart issue in terms of being SVT, but hypoxia and stimulants and alcohol can also trigger it in somebody who is more prone to having SVT. They usually complain of chest pain and palpitations. They say it feels like their heart is beating out of their chest. They might have a syncopal episode, be really tired, sweating, feel really short of breath. Treatment for these are some vagal maneuvers. So we will have a patient either bear down like they're having a bowel movement, or have a syringe in their mouth and try to blow the syringe out. Sometimes those vagal maneuvers work. On kids, they will put like a bag of ice on their face, and all of this is meant to slow down the heart, triggering a parasympathetic nerve that innervates the heart to kind of stop this cycle of the heart beating too fast. If that doesn't work, then an ALS provider will give a medication called adenosine, and they obviously give that by IV, and it has a very short half-life, meaning you need a large bore IV in the AC so that it doesn't take a whole lot of time to get to the heart to have its effect. If the medication doesn't work, then the patient will get some electricity, and neither the medication nor the electricity in the form of cardioversion feels good. Okay, the next one we're going to talk about is atrial fibrillation. So this one, just off the bat from your general impression, you can see that it's irregular and there's kind of just some squiggly lines here. So we don't really see a P wave anywhere in here because all of these little squiggies are essentially the atria contracting at 100 to 150 to 300 times a minute, and we can't really count them. If you introduce yourself and shake their hand and feel their pulse, you will feel it to be irregularly irregular. So we can't really accurately count a rate here either. You would have to palpate their pulse for a full minute to get an accurate rate. So in terms of AFib, there are no P waves that we can find. The atrial kick is lost, so when the atrias are contracting normally, most of the time the atria feed the ventricles by gravity, and then the contraction is what we call the atrial kick that finishes filling the ventricles. Without that atrial kick, the ventricles aren't full, so when they contract, not as much blood is being ejected. That's the decreased cardiac output that people get with AFib. Some people have AFib and they live with it all the time. They are often on a blood thinner because as the atria are beating or quivering 300-ish times a minute, they run the risk of developing blood clots in their atria. So they're routinely put on blood thinners to prevent those things being blood clots. If you have a patient who has an irregular heart rate and they have a history of AFib and they fell down, that would be your first clue to ask if they take a blood thinner to help you determine what kind of transport they should have. If they fell and they hit their head and they're on a blood thinner, they probably should go by ambulance to the hospital. So typically, if people have chronic AFib, they may not call you for it. So you may go for another reason and they just happen to have AFib as part of their medical history. So just because somebody has AFib doesn't mean that we need to do something about it. Sometimes though, if it's a new onset of AFib, they may have complaints of fainting or confusion or difficulty breathing when they're laying down or fatigue. And sometimes they will have AFib at a normal rate, but they call you because their heart has been beating really fast. And sometimes that's called AFib with RVR, or rapid ventricular response. And again, if their heart is beating so fast, they are losing more and more cardiac output because of the fast rate. So ALS providers or the hospital may use medications for rate control. It's not going to fix the AFib, it's going to fix the fast rate of the AFib. So for us, it's supportive care. Alrighty, talking about some atrioventricular blocks. When we're looking at that PR interval, this is where we are essentially looking for heart blocks. So remember that PR interval should be 3 to 5 small boxes, or 0.12 to 0.2 seconds. If it's longer than 2 seconds, but every P wave has a QRS complex, we're going to call that a first-degree block. And typically, there is not an EMS intervention for a first-degree heart block. As the heart blocks go up, they become more and more serious. So a second-degree type 1, sometimes called a Winkie-Bach, that PR interval gets longer and longer and longer for each QRS complex, and then eventually it drops the QRS complex. So in that situation, the patient may say, it feels like every once in a while my heart skips a beat. And essentially it does, because the QRS complex is where they feel the beat, the ventricles contracting, and this is where you feel a pulse. So if you're feeling their pulse, you will miss a beat every once in a while. If they're on the monitor and you're listening to the beep of the monitor that typically beeps for every QRS complex, you will not hear a beat. And that may clue you into, like, look at it to feel their pulse, to ask a little bit more about how they're feeling when that happens. Second degree type 2, the PR interval is the same until a QRS complex is dropped. So it doesn't get wider and wider like the type 1 does. And then finally, a third degree heart block is very serious. This requires immediate intervention in terms of electricity from an ALS provider. So normally the P wave, or the atria depolarizing, triggers or drives the ventricles to depolarize. And in a third degree heart block, the two aren't working together. So the atria are doing their thing and the ventricles are doing their thing. And it tends to be a pretty slow heart rate because the ventricles have an intrinsic rate that's slower than the atria. So here's a picture of the different heart blocks. So this one right here is a first degree. So you can see down here with the P waves, there's quite a distance between the beginning of the P wave and the beginning of the QRS complex. It is 360 milliseconds. So it looks like it's about 2 boxes, actually, if I'm seeing that right. This one down here is a second degree type 1. And this is the one where the PR interval gets longer and longer and longer and then drops. So here, it's a pretty normal PR interval. This one is a little bit longer. This one's even longer. And then finally, we drop the whole QRS complex. This one, and we're getting more serious as we go, is a second degree type 2. So this one, the PR interval is the same. We drop a complex, and then it's the same, the same, the same. And these people are having probably more complaints of their heart skipping a beat, they're feeling a little short of breath, a little tired, things like that. This one finally is our third degree, and you can see that there's a lot of P waves. There's a P wave in here. It's hard to see it because there's also a QRS complex, and a P wave and a P wave and a P wave. And then you have a QRS complex and a QRS complex, but they don't seem to be driven by the P waves. So this person is either unconscious or really complaining of chest pain or chest heaviness, fatigue. They don't want to get out of bed. They can't get out of bed. They're dizzy when they get out of bed. This person needs to go to the hospital lickety-split and likely have an implanted pacemaker put in, and an ALS provider, depending on how symptomatic they are, will start pacing the patient. Nothing good is happening with this third degree heart block. Alrighty. Moving on to some junctional rhythms. These are coming from the AV node. The P wave or the atria are not causing the ventricles to contract. The AV node is causing the ventricles to contract. So a junctional rhythm is slower than normal, so about 40 to 60. And obviously junctional bradycardia, like it says, is less than 40. And an accelerated junctional is the right rate, 60 to 100, but the P waves don't look like they should. They can be either inverted, so pointing down, or they can be missing because they're in the QRS complex. So what's happening with this is the AV node is causing the ventricles to contract and then the atria to contract. So they're kind of not going in the right order, which is why it looks funny to us. And I don't have any pictures of junctional rhythms. The next one is an idioventricular rhythm, and this is coming from the ventricles, which means it's slow and it's going to be wide. So if we were looking at the length of the QRS complex, the fifth step in our systematic approach, we would go from here to here. So that's a lot of boxes. I can't count the number of small boxes, but it's wide and it's slow. And these folks may be, again, complaining of some chest pain, some fatigue. They might be unconscious depending how fast it is. They might pass out if you stand them up. They need to go to the hospital to a cardiologist for this rhythm. And you're going to hope that it doesn't degrade into a VTAC or a VFib or an asystole even. Next we have some premature ventricular contractions, or commonly called PVCs. It's an early contraction. Something is irritable in the heart, something is in the electrical system is irritable. And that can be caused by trauma, genetic problems. As people get older, they have more PVCs. A few of them are not really a big deal. If you have a lot of them in a row, that can be a huge issue because a PVC doesn't perfuse. So you won't feel a pulse when this is happening. So if you don't feel a pulse, that means blood isn't being ejected from the heart. So if they have a lot of these in a row, that's a lot of time that the cells of the body aren't getting perfused blood. These two are the same rhythm strips. One is just stretched out, which makes it a little blurry. So I put the small one in just so you can see a little bit better. So we have this strip that looks fairly normal, right? Normal rate. It looks, well, we can only see one to see if it looks regular, so we can't really judge that. It's got a P wave for everyone. It's a normal PR interval, a normal QRS. We just have this big unperfusing contraction in here. And again, you won't feel it when you're feeling a pulse on this patient. So for some people, it's normal to have them every once in a while. It's not normal to have multiple ones in a row. This is one of those rhythms where your patient may be either conscious and talking to you with a pulse, or they may be unconscious and pulseless and apneic. And it's a transitionary rhythm, so people don't stay in VTAC for very long. Eventually, their heart gets tired of beating this fast, and they will go unconscious, and then their heart will stop, and then they'll potentially be in VTAC for a little bit longer before it degrades into VFib. So our job is to assess the patient. If they don't have a pulse, we're going to start CPR and we're going to use our AED as soon as possible. If they do have a pulse, you need an ALS provider to do some cardioversion. And again, the electricity doesn't feel good, so some supportive care is going to be very important for this nice patient. Okay, things are getting worse and worse the farther we go. So now we've got some ventricular fibrillation, or VF or VFib, they're all commonly called. And this is a non-perfusing rhythm. Obviously there's electrical activity in the heart. That's why we have these kind of squiggly lines or squiggly lines down here. They will be unconscious, apneic, and pulseless. And so we are, as soon as we determine they're pulseless and apneic, we're going to start compressions and get our AED attached and working as soon as possible. That is their best chance of survival, is the electricity from the AED or the cardiac monitor to stop this so that the heart can start in its good normal rhythm again. So ALS providers, depending on their guidelines, may give medications for this. Some guidelines don't recommend cardiac medications anymore. So it depends on guidelines as to medications or not. And then finally, the worst of all is asystole or flatline. Unlike TV, you cannot shock this, because we all know that the AED essentially stops your heart. It recognizes, like in VFib, it recognizes that erratic electrical activity and it says, stop it. The electricity, the shock stops it so the heart can start up again in its good rhythm. With asystole, the heart is already stopped, so you can't stop it more or make it more stopped. There's nothing that the AED can do for this person. So again, unlike TV, we cannot shock this rhythm. We can do CPR, and that's about it. Unfortunately, people in asystole do not have a good chance of survival. ALS providers, if their guidelines say, may give epi for asystole, but again, some are giving it and some are not. It depends on the guidelines. So it might be that you do CPR for a period of time, look for some reversible causes like hypothermia or hypoglycemia or hypoxia or toxins or things like that. We call those the H's and T's. If there's a reversible cause, try to reverse it. If not, there's not a whole lot that can really be done for this person. And that has no bearing on your ability to take care of people. Sometimes people die, and that's just one of the hard things about EMS. You can do everything right and still not get the best outcome. So on that happy note, we will move on to some 12 leads. Now, some providers will go straight to a 12 lead, and others will look at a 4-lead strip. That's what we just talked about, and then looking at that, decide they want to take a closer look and then do a 12 lead. So it depends on who you're working with and what they would like to see done as to if you go straight to a 12 lead or you print out a little 3-lead strip first. I like to see the 3 or 4 lead strip just to get a longer picture of what's going on, and then I will put the 12 lead on. So talking about 12 leads, we're going to talk about where those leads go, what we're looking for, and then talk about what part of the heart is affected when we're looking at the 12 lead. All right, so good placement is really important. You do need to kind of get into the patient's business. If it's a male, nobody cares about like touching their pectoral muscles or anything like that. It's just pretty much a non-issue. But females need to have a 12 lead put on them too. So if you're a professional and you are a male provider, you can certainly put a 12 lead on a female patient, assuming we don't have any cultural considerations that we need to take into effect. If you have a woman who has large breasts, the electrodes need to go under the breast tissue, not on the breast tissue, to get a better picture of the heart. So you may have to move skin around to get to where you need to go. And you can do that with the back of your hand, and then it's not quite as personal as the palm of your hand. So you also have to feel their chest to find the intercostal spaces. So the first place that you're going to go is the fourth intercostal space on the right side, and that's where V1 goes. The next slide has a picture of where they go. V2 is the fourth intercostal space on the left side of the sternum. V3 is going to go between V2 and V4. V4 is in the mid-clavicular line, so the middle of the clavicle, down to the fifth intercostal space. I'm going to skip V5. V6 is in the mid-axillary line, so on the side of them, kind of in the armpit area, in the fifth intercostal space. And then V5 is going to go between 4 and 6. So here's a picture of where they go. With my pointer. So you really got to get your fingers in there and feel those ribs and the space between the ribs to get these in the right place to get an accurate picture of their heart. So where your clavicle attaches to the manubrium or the sternum is right about where the first rib is too. You can see that right here and right here. They are attached to the manubrium. So here's the first intercostal space between rib 1 and 2, second, third, fourth intercostal space. And again, right now on yourself, just feel the space between your ribs and kind of count down with your fingers. So you're going to put V1 on first, then you're going to go over to the other side of the sternum and go to the fourth intercostal space on the left side, right here. You're going to put number 4 on next, so it's going to be in the fifth intercostal space, so down one more, and then the middle of the clavicle comes right down here, and then you can go back and put on number 3. We're going to skip 5, we're going to come around the armpit, kind of at the same level, so we're still in the fifth intercostal space, in the mid-axillary line, so essentially on the side of them. And then number 5 will go between the two. So chest needs to be prepped just like you did for your 4 leads, right? They need to be clean and dry and free of hair to get the best possible tracing that you can get. And so things that you're going to look for with the 12 lead. There are 10 electrodes on the patient, but it's giving you 12 different pictures of the heart. So these are some things we're going to look for. We're going to look for ST elevation and depression, and that's looking at that ST segment. We're going to look for inverted T waves, Q waves. I'll talk about what reciprocal changes are, and then more advanced that we're not even going to talk about today, axis deviation and enlargement, bundle branch blocks, things like that. So reciprocal changes has to do with how those leads are bundled together or grouped together. When we're looking for significant elevation or depression, they need to be in 2 or more congruent leads. So 2 or more in that group of leads. Reciprocal changes is elevation in one group. Reciprocal changes would be depression in another group. Hopefully that makes a little more sense with this slide here. So one group is the inferior leads. So if we were looking for elevation, it would need to be in two of these 3 leads. And then reciprocal changes would be ST depression in another group. So ST depression here and here, or here and here. So the colors are grouped with the part of the heart that those pictures are looking at. So this poor soul is not having a good day. So if we look at these leads, we can see on lead 1 right here, there's not any ST elevation. But if we look at lead 2 or lead 3 or AVF, those 3 are congruent leads. They go together. They're all looking at the inferior part of the heart. We can see here we have this isoelectric line, right? And clearly we've got a whole crap ton of ST elevation. In all 3 leads, ST elevation in 2, ST elevation in 3, and ST elevation in AVF. If we look for reciprocal changes, in this other group here, we've got isoelectric line, we've got some significant ST depression here, ST depression here, and we've also got a little more elevation here and here. This fella, or lady, I don't know which, needs some aspirin, assuming it's not contraindicated, potentially needs oxygen, assuming she's not at 100%, or we don't want her to be at 100%. We want her 94 to 96. She needs, or he needs, IV access, ideally 2 large bore IVs, and needs to get to the hospital sooner rather than later. A hospital with a cath lab would be the appropriate place. If you take them to a hospital without a cath lab, they're going to get sent to one with a cath lab. So part of your care is determining the appropriate destination for the patient, and that comes with wherever you happen to be practicing with the resources available to you. So the monitor interpretation for this would likely say something like acute MI, acute inferior wall MI, and again, if you are transporting this patient because there isn't an ALS person available to you, you would be able to, well, hopefully, you would be able to transmit this 12 lead to the hospital so they could start getting ready for this person who's coming in with a hot MI. Okay, so looking at some blood flow through the heart, we've got the coronary arteries that branch off the very base of the aorta right here. They get their blood supply on diastole when the heart is refilling with blood and the pressure is lower. So they branch off to the right coronary artery, to the left coronary artery, and then it goes to the circumflex, which goes on this picture around to the back of the heart, and then it branches off again to the LAD, or the left ascending aorta. Left anterior descending artery, sorry. So those are the big ones. And we can have a blockage in any of these coronary arteries causing an MI. Okay, so the right coronary artery feeds the right atrium, the SA node. So if somebody is having a really slow heart rate, it could be a blockage in the right coronary artery. It feeds in 70% of the population. Sorry. It feeds the AV node, the right ventricle, the bottom of the heart, and a large part of the back of the heart. So this is our inferior wall MI. So that past picture of that bad 12 lead, the person probably has a blockage of a coronary artery, of a right coronary artery, of the right coronary artery. All right, so I mentioned they might have a slow heart rate, which could also lead to hypotension. They could have any of the heart blocks if they've got a problem with their right coronary artery. The LAD, or the left anterior descending artery, feeds the septum of the heart, so the middle wall of the heart, and then the front of the left ventricle. So looking at your 12 lead, V1 through V6 is going to show potential issues with the LAD. So that would be a septal wall MI or an anterolateral MI. The circumflex artery that goes around the back of the heart, it branches off the left coronary artery where the LAD also branches off, feeds the outside wall of the left ventricle, the left atrium, and then the AV node in about 30% of the population. And these issues can be some tachy dysrhythmias, so we tend to have a faster heart rate in people who have a circumflex occlusion. So this would be 1 AVL, maybe V5 and V6. These are some references that I used for this presentation, various books. I did not put all of the appropriate words for a true reference, but these are the ones that I used. And then we're going to practice just a few of these. So we have a patient, we did our BLS skills, we have plenty of help so we can put the monitor on the patient, and we're going to follow those 5 steps every time. These aren't 12 leads, these are just a 4-lead strip. So we look at the rate at each, making sure we have a P wave for every QRS complex, making sure it's regular from R wave to R wave to R wave, looking at the P wave, looking at the PR interval, and looking at the QRS complex. So I'll give you a minute to think about what you have. And this is a normal sinus rhythm with a rate of 90. And again, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9. So that would be about 90. Or if we start here, 300, 150, 100, a little bit less than 100, so 90. Each complex is complete with a P wave that looks the same. with a QRS complex. It looks to be a regular R to R interval. Nothing crazy, so we can name this normal sinus rhythm. Next one, we're going to do the same thing. We're going to count a rate, look and see if there is a P wave for every QRS complex, if the P wave is upright and looks the same in each one. Is it a regular R to R interval? Anything crazy with the QRS complex? And anything crazy with the PR interval? So this one, I'm just giving you a second to figure it out, is a normal sinus rhythm. Unifocal PVCs mean they look the same. So this PVC looks the same as this PVC. So saying there's one irritable focus in the heart, in the ventricles, as opposed to multiple ones. And multiple irritable spots would be more of an issue than just one irritable spot. So it's about a rate of 60 because we're not going to count our PVCs in this. We're just going to count 1, 2, 3, 4, 5, 6. We've got a P wave for each QRS complex on the normal complexes. It's a regular rhythm, again, except for those PVCs. So we can name it normal sinus rhythm with a unifocal PVCs. All right, so here, again, we're looking at the rate. If each complex is complete with a P wave for every QRS complex, if it is a regular rhythm, anything crazy, and then we're going to name this rhythm. Okay, so what did you come up with? Did you come up with a sinus rhythm? We can't really call it normal sinus rhythm because we do have this ST segment elevation. So you should have counted 10 R waves to give us a rate of 100. Each one has a P wave for the QRS complex. It's a regular interval between these R waves. And the wildly abnormal would be this ST elevation that we're getting here on all of these complexes. So if you had just done a 4-lead, this would definitely be a situation where you would want to put the 12-lead on to get more pictures of the heart. Again, to get a better idea of where the potential blockage is. And this is the last one. So I will just give you a second to figure it out, looking at the rate, P wave for every QRS complex. Is it the R to R interval the same? Anything out of the ordinary? And then we're going to name the rhythm. Okay, so hopefully you came up with a normal sinus rhythm with a PAC. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So a heart rate of about 100. They're all complete. They've all got a P wave for each QRS complex. It's a regular interval except for this one right here, which is premature. And we don't really have a discernible P wave in this complex right here. So it's either buried inside the QRS or it's inside this T wave right here. So otherwise, it's a sinus rhythm with a PAC. And finally, I hope that you got some good information out of this EKG for EMS providers in a basic form. If you have any questions or comments, please feel free to contact me. My email address is right here. My phone number is right here that you can text or call. And thank you for your time. And I look forward to seeing you in person next year.